Zach Janowski with a brief presentation and some commentary.
Thank you, Peter, and Federalist Society for having me here today. While Dr. Pilon explained why the mandate is wrong in a moral and constitutional sense, I want to focus on why it just won't work. One disclosure before I get started: I'm not a lawyer. I'm a journalist, and I have a background in economics, and I'm also just very interested in healthcare policy, which is why Peter invited me here today. Let's start with a thought experiment. You drive into Hartford tomorrow morning, and there is a new sign on the parking meter. Under the new rules of the parking authority, you must pay $20 for 2 hours of parking. Interested to find out why rates have gone up so much, you keep reading. The fine print says clearly, anyone parked at an unpaid meter will be fined $5. It's $20 to park, or $5 to pay the fine. How many of you will pay to park? This is my analogy for the health insurance mandate in the healthcare reform law, commonly called Obamacare. Either buy something really expensive, or pay a fine much less than it would cost. Let's talk real numbers. Effective January 1st, 2014, people without insurance will pay a fine of $95 or 1% of their income, whichever is higher. However, the subsidies within the law set the maximum premium cost for someone, for example, at the federal poverty line, at 2% of their income. In short, the fine is half as much as the maximum premium cost. In 2016, when the penalty rises to 2.5% of income, the decision for people at the federal poverty line becomes easier because insurance will be 0.5% of their income less than the amount of the fine. So it makes sense in most cases for them to buy insurance. However, once you reach 133.01% of the federal poverty line, things stop being so clear. At this point, your insurance cost is capped at 3% of your income, or 0.5% higher than the cost of the fine. Eventually, at 300% of the federal poverty line, or $67,000 for a family of 4, the amount of income allowed for insurance costs rises to 9.5%, or almost 4 times as much as the fine. That's where the parking meter numbers come from. I'm not an expert on crime and punishment, but it doesn't look like what we normally see. If you think white-collar crimes, for example, imagine someone convicted of embezzling $100,000, fined $50,000, but then allowed to keep their ill-gotten gains. Just doesn't make sense. Crime shouldn't pay, as they say. The design of the mandate shows that not having insurance isn't a crime because you're not punished for violating this law. And as Dr. Pilon mentioned, it has to do with this guaranteed issue and the community rating. You're inhibiting the efficiency of the welfare state, so you have to contribute extra to pay its costs. Now, I've asked people who do support the mandate about the disconnect between the cost of insurance and the size of the fine or tax, and they argue people will follow the mandate because they don't want to break the law. I think it is more likely that not having insurance will be treated like a speeding ticket or not feeding the meter when you don't have quarters. It will be a crime, to use the term lightly, without stigma. The argument that the penalty is not a fine, but simply a tax, supports this belief. Offering a tax as a way out of having insurance is a way of giving them permission as long as they pay. If someone who fails to buy insurance is a drain on the economy through free riding, why does it make sense to charge them less than the cost of that burden? And I think the answer is that most people who support the mandate, people on the left, consider it anathema to fine someone who is poor because they can't afford something. This taboo prevents them from instituting a mandate that might actually work. And on this point, I think mandate supporters are probably onto something. If the mandate penalty were high enough to actually work, it would probably lose any remaining popular support. As it is, we don't know how people will react once the penalty takes effect. When Connecticut instituted the income tax 2 decades ago, the public outcry didn't begin until withholding began. We have not reached that point yet with Obamacare. Of course, some people will be motivated to buy insurance because of the mandate. For example, if you want to run for office or have outstanding warrants and don't want to draw attention to yourself. And additionally, some people might make an economic decision to buy insurance. For example, you might decide that paying $8,300 for having insurance is better than paying $2,200 and not having anything. But that is someone with $6,000 of disposable income, and how many people earning, say, $90,000 a year with 4 kids have that kind of money kicking around? The employer mandate, without getting into too much detail, I expect to fail in a similar way. The incentives are not properly aligned, and as all conservatives know, people respond to incentives. When I worked at a local weekly, I covered an appearance by Congressman John Larson in our town, and he said something that helped me to understand better where he was coming from on the healthcare law. Premiums may increase for some people, he said, but your out-of-pocket costs are going down. This attitude sums up the Obamacare approach to healthcare. It doesn't matter if it gets more expensive as long as you end up paying less. Unfortunately, this attitude is unsustainable fiscally, and it does nothing to accomplish the stated goals of many on the left, which is to expand access to healthcare. I want to take a step back and look more broadly at the way the government tries to reach this goal. From what I can see, the government is focused on healthcare demand without even looking at the supply. Let's do another thought experiment. We run an auction house charged with selling 60 antique teapots. We expect our teapot auctions to be similar over time. During our last auction, 100 people attended and we reached a clearing price where the average teapot sold at $100. Since then, President Obama has learned that 40 people were left without antique teapots. Since his mother was an avid teapot collector who could never afford one, he springs into action and issues, by act of Congress, 20 vouchers for an antique teapot to the 20 collectors with the lowest incomes. These vouchers must be redeemed by our auction house with a teapot in return for only $20, well below the clearing price. What happens at our next auction? 100 people attend and 20 people automatically get teapots. The remaining 80 people now compete for 40 teapots, and 40 people still can't afford teapots, the same number as before. My hypothesis: government programs that seek to expand access to healthcare change who can afford it without increasing how many can afford it. In other words, most of the time the government expands access to one group, it reduces access for another. Now, the healthcare market is not as discrete or static as the one for antique teapots, so I would project the ratio as not 1 for 1. There is some net increase in healthcare access, but at a cost to everyone else in the system, including a very high cost to the people who could afford healthcare before, but now can't. And unfortunately, these people are the least wealthy of the group who could previously afford healthcare. A more valuable approach would be one that looks at supply. Here are 2 examples that show the problem with healthcare supply. The number of MDs produced per year in the US is essentially unchanged since 1980. Over that same time period, population has increased by about 1/3. After doubling over the previous 20 years, the number of new doctors created each year peaked at 16,000 and has remained near that level since. There are a number of factors that would suggest this number should have increased over that time. Greater wealth, aging population, government programs that seek to expand access, new technology, an increase in the range of treatable conditions. That's just to name a few. The medical profession, largely with the consent, if not the agency of the federal government, has sought to restrict the supply of MDs. These guys could teach OPEC how to run a cartel. I would suggest medical students today are more qualified because the profession has created guild-like tests of commitment to the profession, much like weed-out classes at universities and certain popular majors. Just one simple example of this over-credentialing is the proliferation of master's degree programs that mimic the first year of medical school. They have no educational value, since students who go on to med school repeat the curriculum in their first year. The purpose of the program is to eliminate people who want to be doctors but won't spend the time or money on the extraneous degree. Lawyers don't have the same protection. Law schools just keep producing lawyers, often the very people who aren't sufficiently committed to becoming doctors. Based on my anecdotal experience, small-town doctors make more than small-town lawyers. If anyone here has evidence to the contrary, I'd be interested to know. Contrast the 16,000 new doctors each year with the 45,000 law school graduations, if ever there was an argument for tort reform. Another problem with the supply of healthcare is the decrease in competition among hospitals. Community hospitals have the connections, that prevent them from becoming political punching bags like insurance companies. Plus, people don't see when hospitals raise their rates, while they do see insurers raising theirs. Of course, government is partly to blame for driving hospitals to consolidate through Medicare and Medicaid distortions in the market. Let's just look at one simple, brief example of this phenomenon. Hartford Healthcare, the network run by Hartford Hospital, is close to where I live in Southington. I used to have Bradley Memorial Hospital, nearby New Britain General Hospital, or Hartford Hospital to choose from, but now they all belong to this Hartford Healthcare entity. Of course, from my perspective, it doesn't change much because I still may have a preference based on location, range of services, and the quality that I perceive there, but insurance companies negotiating with Hartford Healthcare have fewer options. The insurers need to include Hartford Healthcare, and Hartford Healthcare knows it. This has turned community hospitals, nonprofits for the most part in Connecticut, into oligopolies or in some cases local monopolies. Last year I heard anecdotally that hospital groups were seeking an increase of more than 15% per year each year for 3 years. When insurers' cost basis goes up by 15% annually, it is an act of mercy when their rates go up by less. The hospitals have made the state regulate, and then the other thing is the hospitals have the state helping them to regulate supply through the certificate of need process, which they sometimes support and sometimes oppose, but it's just another way. For example, there's a neurology practice in Norwich, Connecticut, that they have an MRI, but they're only allowed to use it for neurological cases. And they applied to the state to ask for permission to say, can we have other people who need an MRI to use this machine? They said, no way, that would create too much demand for this product. So I think it fundamentally misunderstands the economics of healthcare. So I think to address the supply constraints, the federal government, first of all, should stop helping doctors limit the number of people who enter the profession. And we could also look at new ways new approaches to the way the government subsidizes healthcare. Rather than provide insurance for the poor, provide reinsurance or stop-loss coverage for everyone. For example, if the government pays for annual costs above $100,000 per person, the cost of insurance would fall for everyone, and there is little incentive to increase your health expenditures above $100,000 annually. Most people who do end up in that category don't end up there through their own choices. An approach like this would allow healthcare markets to function more effectively than they do now and show that little government intervention is needed.